should tell you that patient is an acute kidney injury, because the biggest mistake what all of us do is that if the output is good, we presume that everything is all right. And 1 creatinine to 1.3 creatinine, we are not going to give much importance to it. So understand that not only a drop in urine output, but also a rise in creatinine of as small as 0.3 milligrams should tell you that somebody is an acute kidney injury. As Bala said about the various stages and various complications that can happen in chronic kidney disease, this is also true for somebody with acute kidney injury. A normal person, anybody who is admitted in the hospital is a candidate for a potential acute kidney injury. Be it cold, cough, fever, be it any normal routine surgical procedure or a complicated thing, or anybody in the intensive care unit, presume that he is at risk of developing acute kidney injury. Unless you are going to suspect this, you are going to miss out on this. And as the stage of acute kidney injury increases, the patient's GFR comes down, and he is going to get into more and more complications because of acute kidney injury itself. So the point what we learn here is an acute kidney injury is the term. Don't call any longer as an acute renal failure, and it identifies the injury to the kidney much before the creatinine starts rising, and you can diagnose it in the bedside. You don't need any sophisticated equipments or investigations. Just by looking at the output for 6 hours, you can diagnose that this person is an acute kidney injury. The question is, why should I identify? So what if the output is less? What am I going to do as a non-nephrologist? Somebody has got a creatinine of 2 milligram, which is mild kidney failure. Many times we see that patients with diabetes, especially in chronic kidney disease, they say diabetes, hypertension, 1.4 creatinine, 1.8 creatinine, mild kidney failure. So is there anything called as mild kidney injury or mild kidney failure? The question is what I can do as a non-nephrologist. So when somebody's output is less for 6 hours, what he should do? One, look on to the drugs, what the patient is taking. Is this drug is potentially causing damage to the kidney? The commonest drugs are NSAIDs, aminoglycosides. If somebody has got any investigation, especially a contrast, all these are potential drugs which can cause damage to the kidney. Remove as much as possible at the earliest. Ensure the patient is hydrated properly. Many times patients are not hydrated. In fact, yesterday I saw a patient in Railway Hospital. This patient has got an elderly female, rheumatoid arthritis, COPD, severe right heart failure, and patient has got a urinary tract infection and drop in output, and patient is on dialysis. The best thing what we should do is hydrate the patient. They have been worrying about decreased LV function, they are worried about pulmonary hypertension and so on and so forth. And unless you are going to hydrate somebody, we are going to be in misery. Like Bala told, we have seen many times patients with raised creatinine are absolutely on a salt-free diet. And we have to tell them that patients should take salt. There is absolutely no connection between the urea and the salt what they are going to take. So ensure that patients are adequately hydrated, and as much as possible ensure that the baseline blood pressure or mean arterial blood pressure is maintained, and monitor the creatinine and urine output. This is very important. You should tell the nurses, educate all your nurses in your hospital, especially the intensive care unit, the importance of output. Many times they don't even tell you. Like when you see the patient in the morning and then you're busy in the theatre or in the outpatient, you come back after 12 hours or 24 hours, they say the output is less, only 50 ml the entire 12 hours and so on and so forth. That should not be there. Educate all your staff to tell them that the output drops, to inform you. And avoid hyperglycemia, and as much as possible avoid contrast procedures if that is going to be not all that necessary. Suppose if the contrast is going to be life-saving the situation, go ahead and do it. And as much as possible investigate them, ensure that basic investigations like an ultrasound is done, not to miss out an obstruction. Many times patients say that there is no urine output, either there is a distended bladder or there is a blocked Foley's catheter. Ensure that this is not there. In fact, when we are in Apollo Hospital, many times patient voids in the toilet, they don't even tell the nurse, so you get a call at 12 o'clock, patient is not voiding any urine, please come and see. Correct? So all these things ensure that we don't miss out on all these things. Okay, so patient admitted in the hospital and was identified as increased urea and creatinine. The question is, we know what to do in CKD, we know what to do in AK, but the problem is it CKD or is it AK? How do you differentiate between these two entities? Is it because of output? Is it because of blood pressure or severity of renal failure? Because many times we are asked these questions by a lot of family practitioners when we give talks elsewhere. Output is less, acute renal failure. Output is more, chronic renal failure. There is hypertension, acute renal failure, normal blood pressure, chronic renal failure. Creatinine of 2 acute renal failure, creatinine of 10 is chronic renal failure. That's a question what all of us are